Hi, everyone. Welcome to the University of Toronto Joint Center for Bioethics Seminar Series. I'm Angel Petropanagos, and I'll be the moderator for today's session. Our speaker today is Daniel Sperling, and his seminar is entitled, Is Suicide Tourism a Moral Phenomenon? Before I introduce today's speaker, I'd like to let you know that the seminar is being recorded, and this lecture, along with other archived lectures, can be accessed through the Joint Center for Bioethics website. Our format of our seminar today is a presentation by our speaker, followed by a facilitated discussion period. First, we'd like to take a moment to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. We also stand in solidarity with the ongoing protests against racism and systemic discrimination. Now, it is my pleasure to introduce today's speaker. Professor Daniel Sperling is an associate professor in bioethics in the Department of Nursing at the University of Haifa, Israel. He holds a Bachelor of Law degree, a Bachelor's in Philosophy from the Hebrew University of Jerusalem, and a Master's of Law, Collaborative Specialization in Bioethics, and a Doctor of Judicial Sciences from the University of Toronto. Professor Sperling is also the author of 3 books, Suicide Tourism, The Understanding of the Legal, Philosophical, and Social Political Dimensions from the Oxford University Press, Posthumous Interests, Legal and Ethical Perspectives from Cambridge University Press, and Management of Post-Mortem Pregnancy, Legal and Philosophical Aspects from Ashgate, as well as other numerous articles and books and chapters in the area of ethics, law, and bioethics. Now, again, it is my pleasure to turn it over to you, Dr. Sperling.
Okay, so good afternoon, and thank you very much for the opportunity to present my work at the JCB. I'm very excited in doing so, having graduated from the JCB collaborative program and also worked with Peter Singer on a fascinating project on advanced directives in Canada back then in 2003. So in today's talk, I would like to discuss the phenomenon of suicide tourism, which is the subject of my recent book published by Oxford University Press in 2019. I will regard this phenomenon, whose terminology attracts much criticism, as an evolving end-of-life issue, which provides a fascinating opportunity to ask questions about death and dying and to reflect on their social and political dimensions, thereby extending and going beyond the individualistic perspective which most of the literature focuses on. I will switch now to PowerPoint presentation, which I prepared for this talk. So unlike most of the relatively few countries which permit assisted suicide in the laws, Switzerland does not disallow this practice from non-residents. The law in Switzerland permits assisted suicide if made under non-selfish reasons. In contrast to the laws in the US, which are primarily based on the Oregon Death with Dignity Act, specifically requiring that the patient at stake must be a resident of Oregon, the law in Switzerland does not include such a requirement. Moreover, unlike the Dutch law or the law in Luxembourg, the Swiss law does not ask for a continuing relationship to occur between the patient and her prescribing physician. Now, in Canada, interestingly, under the MAiD, a person may receive medical assistance in dying if they are eligible but for any applicable minimum period of residence or waiting period would be eligible for health services funded by a government in Canada. This residency requirement goes further than the proposal set by the Senate Advisory Committee and a provincial territorial expert group, where it was recommended that eligibility for medical assisted aid in dying should be based on existing eligibility for public health care insurance. The rationale for the residency requirement, according to the Senate Joint Committee report, was twofold. MAiD should occur in the context of a physician-patient relationship, and the committee does not want Canada to become a destination for people seeking MAiD. Furthermore, it is based on the process leading to this legislation that such a provision was intended not only to limit suicide tourism to Canada, but also within Canada. So generally, in recent years, there has been an increase in the number of people traveling to Switzerland for assisted suicide. And you can see the increase in the accompanied suicide cases with, for example, the major organization, Dignitas, and also registered members with Dignitas. But the question that I would like to raise today is whether suicide tourism is a moral phenomenon, and are there stronger moral arrangements and arguments to justify it with regard to its morally acceptable phenomenon. This question is not only theoretical, but also has practical implications in law, ethics, and public policy. So legally, if one argues that suicide tourism may be permissible, then there would be no reason to prosecute subjects of failed suicide attempts or any third party assisting a person to travel for assisted suicide, including an organization, a medical doctor, a lawyer, forces. From a moral and ethical perspective, the argument that suicide tourism can be justified implies or may lead to an analysis exempting health or legal professional from moral or ethical condemnation when supplying, for example, information that may support an application for assisted suicide or advice and help in carrying out such plans. On public policy level, normative support for suicide tourism provides the state with regulatory authorization that affects the extent, content, and limits of its regulatory power, should it exist. So in my talk, I discuss and provide the moral basis for a response, whether countries from which people travel to receive aid in dying should shape, regulate, and enforce policies pertaining to such practice depends on the moral and philosophical justification for and against suicide tourism. These should be distinguished from the justifications for and against assisted suicide. There is, of course, a connection between these two. One who regards suicide tourism as a morally sound practice will almost certainly also believe that assisted suicide should be permitted. But the opposite is not necessarily true. Even when there are good reasons to believe that assisted suicide is morally permissible, this does not automatically lead to the argument that travel from one country to another for assisted suicide is morally acceptable. I will now refer to three key arguments in support of suicide tourism, and these are mentioned here. While still subject to some conceptual debate and criticism, the right to die requires that people should have power to determine their way, time, and place they depart from the world. Usually such a right refers to the concepts of liberty, autonomy, dignity, respect, concern, quality of life, and suffering. Thus, the right to die is supported by the patient's liberty, her autonomy to make fatal decisions, her desire to maintain her dignity, and the healthcare profession's obligation to guarantee that the patient's dignity is preserved. Furthermore, the right is justified by a shared commitment to respect and to show concern for vulnerable patients and to evaluate and reflect on quality of life considerations, alleviation of pain, and avoidance of suffering. It will be argued that the right to die is so essential to human flourishing and well-being that it should be viewed as a human right. Under this argument, a person who regards her life as unworthy and who expresses no wish to continue living is at her most frail. Human frailty derives from the condition of scarcity. disease, and danger. Facing inevitable death is a common feature to all human beings. The right to die includes all of the major characteristics of human rights. It has a right holder, relevant parties who are assigned responsibilities pertaining to it, and a clear scope. It has a pluralistic account referring to the combined values of autonomy, liberty, and human vulnerability. It is universal and does not depend on the existence of a particular society or nation, applying it to a creature who has the potential for normative agency. And it has meaningful and significant norms supporting the high priority placed on it as a human right. If one accepts this argument from universalism, it follows that a human being should be able to exercise this right to die in another country if her own country limits or otherwise prohibits such an act by, for example, the prohibition of assisted suicide. Hence, suicide tourism can be justified on the ground that it allows and guarantees the human right to die. Moreover, without defending this practice, the human right to die does not receive any practical meaning and instead remains on a theoretical level. Another justification for suicide tourism concerns the value placed on the moral right to move about freely and its application in the context of access to health, or more specifically, health-related services. It can be argued that allowing people to move to other geographical settings within and outside one's country according to their wishes and needs is not only instrumentally important in enabling them to determine as much as possible the circumstances under which they live and die, but it is also intrinsically important to their value of autonomy. This is because being confined in one's movement can be experienced as a constraint of freedom itself. Other justification for the moral right to free movement may apply particularly to suicide tourism, insofar as the place of birth is morally arbitrary and people should not be held to it. A commitment to moral equality of humanity cannot justify limitation of a person's right to freely move from her place of birth, thereby also to escape from its laws. On a political and macro level, movement to another country to fulfill one's wishes by escaping a state's laws and moral conventions prevents moral homogeneity and promotes diversity and experimentation. Finally, if one accepts the World Health Organization's definition of health, referring to the well-being of a person as a major component of health, then accessing services to pursue a person's well-being, including assisted suicide or medically assisted in dying, medical assisted in dying, may be justified by a person's right to freely and deliberately move from one place to another to access services that promote her complete health. States and perhaps also citizens hold a moral obligation to offer international humanitarian aid to their fellow humans when the latter face a state of natural disaster that potentially or actually affects a significant number of people. Traditionally, international aid, which usually involves the donation of domestic resources, is provided to victims of such disasters as floods, famine, epidemics, earthquakes, etc. Corollary to such an obligation is a person's moral right to receive such aid, including through being allowed to travel to the donor country to receive it. Providing humanitarian aid is influenced by humanitarian considerations and can be justified as a reaction to human suffering. Countries that consider providing international aid, it is argued, do and should go beyond their own national self-interests. Under this third argument, the expression of human nature in international politics requires prudence, awareness, and moral concern. The moral obligation to offer humanitarian foreign aid is supported by the value of solidarity that applies to all citizens regardless of territorial limitations. It can be argued that such an obligation could be applied to the situation where people in some parts of the world who suffer from pain or poor quality of life cannot fulfill the right and wish to die due to legal or social limitations. It is contended that such a situation classified as a social disaster equates to a natural disaster, justifying humanitarian intervention. That a moral obligation is owed by the Swiss people, including right-to-die organizations, who are not only subject to permissive laws on assisted suicide, but are also capable of offering such services to non-residents, can be established by reference to the idea of an unreciprocated gift, and more generally, as an expression of the power relations between Switzerland and other countries and their residents. Like any other gift, providing access to assisted suicide to foreign residents establishes both interested and disinterested relationship between Switzerland and other countries. It allows the former to preserve and perpetuate its image as the oldest neutral country in the world, and by giving to others the means of providing assistance in death, an act which is so widely inaccessible and impermissible, to maintain what Pierre Bourdieu calls symbolic dominion, or a practice that singles and euphemizes social hierarchies. Along with the justifications in favor of suicide tourism, one should consider four major justifications or group of justifications against such a phenomenon, and I will refer to them now. One of the strongest arguments against suicide tourism refers to the implications for serious and detrimental outcomes raised by such a practice. Allowing people to travel to other places for the purpose of committing suicide may be harmful in cases where ending their lives may be the result of an abuse, financial or otherwise, and or does not follow a candid wish to die. If unsuccessful, attempts to commit suicide, which are illegal in one's home country, may make the people involved behave more immorally and incentivize them to engage in more dangerous, immoral, or even criminal activities. If people who explore traveling to another country for assisted suicide reconsider their decision to commit suicide, or are recklessly being assisted, and as a result, their health status worsens, this may aggravate their suffering, extend their terminal condition and the dying process, and create serious financial and emotional burden for them. As to accompanying partners, it can be argued that these people can be exposed to criminal prosecutions or otherwise social condemnation when they are back in their homeland. While attending suicides of their beloved ones, they may suffer trauma and feel hurt and guilt for not supporting and opposing opposition. They may also be exposed to financial pressure and abuse by the right-to-die organization or other mediators who facilitate the proposed travel or are providing professional help for it. Overall, their close involvement in this experience may make them behave more immorally or engage in dangerous or criminal activities in the future. As to consequentialist considerations pertaining to third parties or society at large, these include the so-called slippery slope arguments concerning the detrimental effect that suicide tourism may have on vulnerable people, for example, children, the elderly, patients, or people with disabilities, and so forth. Specifically, such a practice, it can be argued, will increase disrespect towards these groups of people and increase the ease with which ending their lives can be brought about. Validating the practice of suicide tourism may also lead to unethical or legal practices by physicians and caregivers and reconstruction of their professional obligations toward their patients. This will erode patients' trust and damage the reputation of the medical profession. On the state level, suicide tourism may hurt the image of the permissive country, for example, Switzerland, and may also affect its relations with countries of origin. Although it may bring some economic growth, it may lead to abusive and illegal activities being performed by its members and expose innocent parties to criminal and immoral behavior. Under this second rationale, human beings should not enjoy or hold moral right to travel or to another country to commit suicide or to be assisted to do so. While this argument stems from the more general objection to suicide, it nonetheless holds that the practice of suicide tourism intensifies the conditions under which these objections apply. And there are several aspects to this argument. One aspect concerns the inviolability or sanctity of life and regards the intrinsic value that life has so that it must not be taken by human action. It is argued that the practice of suicide tourism emphasizes the artificial or unnatural aspect of dying, increasing the involvement of others in this process, including family members, friends, agencies, assisted suicide organizations, professionals, bureaucrats from both countries, etc. As the dying process becomes more human-made and dominated by unnatural factors, the value attached to life diminishes and, if at all, receives weight only for its instrumental contribution to other external values. The substantial diminution of the value attached to life makes a strong case against the practice of suicide tourism. Another aspect to the opposition to suicide tourism concerns the irrationality of suicide that becomes more evident by the practice of suicide tourism. It is argued that the practice of suicide tourism emphasizes the advanced planning of the act of suicide, including the place, manner, conditions, surroundings, and possible consequences of taking one's life, all of which are dominated by the rules of the market, especially supply and demand of assisted suicide services, operating under the assumption that the more and the better information results in better and, from this perspective, a more rationalized outcome. Whether rational autonomous decisions can or cannot pertain to committing suicide following the concept of humanity or deriving from the content of such decision, suicide tourism cannot be supported morally, as such a practice rests on and heavily emphasizes the making of rational decisions that by themselves cannot stand in a coherent and morally justified relationship with the act of suicide. Under this third argument, while suicide tourism empowers one's dominion over the body as it reflects intimate choices pertaining to one's body, it is through the movement or travel of such a body that it transforms and annihilates itself. One can argue that a person has a moral duty to respect one's body and to make it function, thereby realizing one's humanity to the full. In this respect, suicide tourism is different from other forms of medical tourism, where the body is altered, fixed, and revitalized, but is not annihilated. If one follows this conceptualization, one would argue against a practice that refers to the traveling body as a means to annihilate the body through the assistance of another person, not just as a mere contradiction to morality, but as an act of disrespect towards the person through her body. The fourth argument is the argument from the nature of dying. While the physical move from the familiarity of home to a hospital setting transformed the person to a patient, with suicide tourism, the dying process takes place in a totally unfamiliar, remote, and alien environment, at times even isolated and artificial. It can be argued that the practice of suicide tourism substantially alters the process of dying so that it empties the symbolic and emotional meanings attached to it and depletes the dying person's personality and identity linked to her original culture. Moreover, accompanying parties are sometimes investigated when they return to their homeland, and thus their experience of the death of a loved one becomes one from the perspective of potential criminals. In addition, because suicide tourism involves parties other than physicians, such as those who facilitate the travel and are responsible for administrative, legal, and technical issues, suicide tourism involves financial compensation and gives rise to a market which in turn fosters profit-based motivations amongst people involved. The travel itself is being regarded as an insurance plan. As this becomes a major characteristic of suicide tourism, dying under this practice is transformed from a humane and incentive-free process to a commercialized, self-interested, and uncaring practice, which is unjustly accessible only to those who can afford it.
It is thus argued that because these changes are a threat to human life, which also consists of the way we die, suicide tourism should be warned against and cannot be justified. While the justifications for suicide tourism are powerfully convincing, those against it, I would argue, suffer from theoretical problems and in some cases cannot necessarily be supported by empirical evidence. Indeed, suicide tourism provides individuals with much freedom and choice in exercising a right to die, which should receive greater weight than in the case within current moral and legal understandings. The tourism adventures secures an element of escapism from, for example, the physical and psychological effects of chronic or terminal disease, and a sense of achievement following some fantasy over the place, manner, and personnel involved in the dying process. These advantages accord with people's expectations when pursuing suicide and assisted suicide. They also correspond to people's right to free movement, which is more secured and valued in globalized world and can also be supported by a revised and more courageous interpretation of the moral duty to provide humanitarian aid to citizens of less permissive states. Meanwhile, the consequentialist considerations against suicide tourism have not been proven. While there is only a little anecdotal and indirect evidence to suggest that cases of suicide tourism involve abuse, there are hardly any cases reporting regret, inclination to be involved in other morally or criminally impermissible acts, or other health-inflicted injuries in cases of unsuccessful attempts to commit suicide pertaining to main actors and more generally to accompanying members. As to the latter, data suggest that there has not been even a single case of successful criminal prosecution in any of the countries from which travel has originated. The only case in which a prosecution was brought against an Italian activist did not result in an actual charge. Moreover, there are some positive affirmations, especially in the UK, following the revised guidelines of the Director of Public Prosecutions, to suggest some degree of legal immunity under such circumstances. The argument for moral right to commit suicide should have force if one accords higher moral weight to the right to life than to other competing rights and in interests that are associated with and protected by the right to die. Of course, a morally pluralistic society cannot prima facie account for such a hierarchy unless other considerations support such a conclusion. Regarding the critique from the perspective of rationality, people can, as studies show, make perfectly rational decisions to engage irrationally, even if only instrumentally and not necessarily telically, to harm themselves and to bring to an end their lives in accordance with their fundamental interest, including what they project as their future ends. Yet the requirement of rationality is neither a necessary precondition to making suicidal decisions, nor a conclusive element in realizing such decisions. Moreover, it could be argued that suicide tourism does not necessarily make suicide decisions more rational, as these are prone to market failures deriving from the complexity associated with the decision to commit suicide or to end one's life, as well as the emotional burden associated with such decisions. With regards to the argument from the human body, it should be emphasized that the moral duty towards one's body, if it exists, is dependent upon the functionality of the body or the body parts and its contribution to self-preservation. However, when the body or body part becomes a threat to oneself and one's life, even Kant would have regarded such a case as an exception to maintaining the duty not to mutilate oneself. Finally, the arguments as to the nature of dying does not necessarily lead to invalidation of suicide tourism, but at most can offer a new or revised way of understanding and conceptualizing the dying process and more generally the concept of health, as this session and talk illuminated. It may suggest a new form of tourism to which Miller and Gonzalez refer as dark tourism, namely the travel to sites linked with death and tragedy, or sites where death and suffering has occurred or been memorialized. Moreover, commercialization of death and dying is being observed not only with regard to suicide tourism, but with other social phenomena whereby society enters a death-deriding age under which, as argued by Palgrey and Walter, death is mocked, commercialized, or sold for the sake of art or entertainment, and is being industrialized through business in various procedures, such as hardware, real estate, and funeral or cryogenic services. In addition, one can argue that in suicide tourism cases, the commodification of death and dying involve the demedicalization of assisted death, thus revealing the true nature of the tourism experience. So it thus follows that there are good reasons to morally justify and protect a prima facie position in favor of the phenomenon of suicide tourism. Regardless of being morally permissible, one must examine further whether such a phenomenon is legally valid and what justification, if at all, do states have in interfering with suicide tourism. And this is done in other parts of my research. So thank you, and that's a view from my university in Haifa and from Tel Aviv, where I live. Thank you.
Thank you, Daniel. That was a really great presentation, and I appreciate the carefulness and thoughtfulness that you took to lay out each of those arguments and responses. So thank you for that. For those, we've got our audience watching on YouTube, and for those of you who have questions, if you can please place them in the chat in YouTube. For those of you who are not logged into YouTube, you can send your question via email to Laurie, Laurie .bulchak, BULCHAK, @utoronto.ca, and she can pass those questions along. You can also use the email option if you'd like to submit a question anonymously. Okay. See, we don't have any questions yet. So while people are thinking and writing their questions in the chat, I thought maybe we could start with, I just had a general question about the language. So the choice of using the word suicide tourism when there are other names for the practices that you've described. So I was wondering if you could say a little bit more about your choice and what you think the implications might be around using that word or not using that word.
Yeah, well, I'm aware, and as I acknowledge, that the terminology is very problematic on both of its parts. So there are arguments saying that what is being done here is very remote from tourism. It's not something that is a positive experience. It's not something that one comes back and returns to her own country. But there is the idea of an adventure, and there is the idea of escapism, as I mentioned at the end of my talk, and so the idea that you consume some kind of a service, as you do like in medical tourism or in other forms of tourism, that you cannot access in your own country, and for this reasons, the literature, and this was incorporated even before I published my book and did my research. There was already this term of medical tourism, of suicide tourism that I used while acknowledging its problem. Also, with regards to the suicide component, people argue that what they're doing here is not committing suicide. There are even professional guidelines explicitly making the difference between medical assistance in dying and committing suicide, either from the perspective of the origin of what leads to such decisions, to the nature of the action at stake. One should recall that in most of the countries that allow assisted suicide, so it's self-administered, unlike Canada, where and Luxembourg and the Netherlands, when the law actually permits euthanasia and assisted suicide. So when the act is administered by others or by the person herself, in most of the countries that permit assisted suicide, it's only by the person. And in this respect, it's doing an action that brings one's life to an end. But I'm aware to this problematic terminology. Yes.
Thank you for that. So we have a question from Karen Deep. They say, thank you for your presentation, thoughtful comments. Would you make a distinction between seeking suicide for terminal illness versus seeking it for escape from life suffering?
Well, I can say that some of my arguments would not support such a distinction. If one believes in a human right to die and its universal ideas, then there shouldn't be any difference. As long as the person is capable of making this decision, understands the consequences of this decision, and so in a way, I wouldn't make this distinction. And I think that in practice, what we see recent years, that this distinction is blurred and is becoming more. These organizations, and we see this also, especially in Belgium, are more open to other considerations than terminal illness and people that are aged, that are just they say that they had enough, or they don't see any value to their lives. There's also what is being extended in recent years, the polypathology basis or eligibility, people that suffer from various conditions, which none of them by its own is serious enough to make them eligible for ending their life, but still the combination and the poor quality of life leads them to this decision. So I think it's very difficult to judge, and make a moral judgment. But as I try to show in this presentation, I think that most of the moral arguments in favor of suicide tourism would assume that such a distinction should not necessarily be valid.
Okay, thank you. So I'm wondering if you can pick up on the one of the earlier comments you made around capacity and that the person is choosing this for themselves. So in Canada right now, the request has to be from a patient who's capable, and they have to be able to consent right up to sort of the moment before the treatment is administered. For now, the law might be changing, but right now this is the current legislation. I'm wondering if you have any thoughts about the importance of capacity given your moral arguments that you've presented us with, and whether you think what it might mean for opportunities for people who might not be capable or might lose capacity after having made the request and been decided that they're eligible.
Yeah, I think moral capacity is crucial here. I mean, because it's, given the seriousness of such an action, one has to assure that the person is capable of making a decision. I think that society and states should invest in promoting advanced directives that would regard to or would include such requests. As they do, with other treatments at the end of life. I think that this is, I'm just now completing interviews that I'm doing with people that are registered with Dignitas. And I understand that Dignitas is one organization, but there are others, of course.
is putting the whole emphasis on the capacity of these people to, and, when we talk about autonomy and we talk about dignity and we talk about the right to die, that is based on these core values, one cannot promote autonomy if the person is not fully autonomous. And there should be serious safeguards to examine and review these conditions.
Thank you. So we have a question from Greg. They say, so thank you for an interesting presentation. They comment, I may have missed in the earlier part of your presentation. And they have a question that's not strictly ethics, but they ask, how common is the phenomenon of suicide tourism in Switzerland? And then as a follow-up, how do the Swiss perceive being a suicide tourism destination? They think that this can be a very intimate journey. Are patients and families well accommodated to be with them as they go through their journey?
Okay.
So a couple questions in there.
Yeah. So Switzerland has become, as I mentioned at the beginning of my talk, as a destination, the central destination for suicide tourism, because it does not require that people eligible for aid in dying would be residents of the specific country. As opposed to most of the other systems, legal systems that allow physician-assisted suicide or aid in dying, and so this has made Switzerland as and interestingly, I just looked for the data with regard to Canadians, whether it influenced the new law, the relatively new law. And so you see an increase in the number of people going to Switzerland from Canada and being members with dignitas. So there is something that is different in this experience, that probably the local solution or the local law does not provide sufficient or does not address sufficient needs that I think it's very interesting to explore. So this is one issue. With regards to the comment, I think that suicide tourism can be an intimate experience. I agree that it can be a very, very intimate experience. And again, I see this in my interviews that I do with people, also with people that accompanied their loved ones to Switzerland and return to Israel. But it can go the other way around. So I met people that don't have accompanying partners, that their family, that they're even unable to speak with their family about these decisions, that it's very tough. So it's very subjective. And there are a lot of issues that people can support their loved ones for their decision, but would not want to go with them. There are people that say, I prefer dying alone and not in my homeland, which is against maybe our intuition that people would love to die at their homeland with their family. So there are a lot of assumptions that we should analyze and think about or rethink.
Mm-hmm. That's really interesting. I wonder if you could say more about the observation that there's more Canadians going to Switzerland for assisted dying, and what those gaps might be, if you have any guesses.
Well, I'm not sure. Maybe the system is too rigid for them in Canada. So they are, one should be aware that people can be members with dignitas, but not execute their plans. So at the end, so they can, and we see an increase in membership, which again leads to the intention that there is some kind of a need that is not being met locally. So maybe they are looking, people that suffer from these conditions that make them closer to the idea that they want to end their life. maybe they are afraid that they won't, pass the thresholds of the local law, and they are just making. This is also something that came up from my interviews. Also, they see this as a safety valve. So this, like an option, like an insurance. Yeah, people also give this metaphor that it's kind of assurance that, if I don't get it here, then I will have it there. So, yeah, for 2019, I saw at least no report of accompanied suicide cases, which is interesting. So, and I'm not sure, why there aren't any data about this. If it's zero, or if they don't want to publish data about this. So I cannot tell about 2019.
Okay, it's really interesting. Thank you.
Yeah.
So we have a question from Caroline. They ask, how does suicide tourism differ from or compare to people traveling to seek medical interventions that are not available or legal in their own countries? So other kinds of medical tourism.
Yeah. I think that one of the major, first of all, it depends how you see medical tourism. If it, promotes your health, again, if you apply the broad conception of health, and, in a way it resembles medical tourism. But I think one of the important differences between medical tourism and suicide tourism, other than the person does not return to her homeland, is that you don't exploit the resources of the country where you go to receive these services, and you don't compete with locals on these services. And when, in medical tourism, you go and, for example, for a surgery or for a treatment, and this comes at the stake of, other people that pay taxes and are. So there is also the access issues and justice issues. Here you talk about something that you give for the person in promotion or in support of one's right to die, which again is a civil right. It's not a social right. It's not an economical right. So I think this is where you see the distinction, that it's more like a human right or a humanitarian aid, rather than just, something that you can buy and compete, and you have allocation issues there.
So Karen actually has a question that relates to the financial aspects. So they ask, are there any concerns by proponents of suicide tourism on increasing disparities based on financial means? So is it that you can only have this right if you can afford it?
Yeah, I think this is what is bad in this phenomenon, that, because there are organizations, right-to-die organizations, that are legally defined as non-for-profit organizations. And so they are not regarded, their action is not regarded by the Swiss government as selfish actions. Recall that this is the requirement of the law, that, if I provide some kind of an aid to a person in making this action, but it's for selfish reasons, that I might be I might be prosecuted. So these organizations, on the one hand, are defined as non-for-profit organization, but on the other hand, they receive a lot of money for it. So they take for first of all, for membership, for annual membership, and then for the consultation that is being involved, and for all the arrangements. So it's a very expensive. It goes to 10,000 Swiss franc for an accompanied suicide.
Is that the cost for a patient seeking the service? It's 10,000 franc. Okay.
Yeah. Okay. Yeah, and so again, this also relates to the previous question, because if you think that this is something that a person should receive regardless of his or her financial status, because it's like a human rights issue. It's not something that is linked to her civil status. Then why should it, why should be really based on such compensation? These organizations say that they have a lot of expenses, and it's only just to cover their expenses, but still, of course it's a lot of money. Yeah.
I didn't know how much it costs. That is quite a bit. So I'm curious,
Yeah.
are there any subsidies or do people do GoFundMe's? I know they do a lot of social media campaigning as individuals. Have you seen this?
I haven't seen campaigns. I don't think people are going out and saying, campaigning for it. I know that people take loans. Again, this is something that I heard from my interviewees, that they took loans from the bank, or had to sell their house just to, so it's something you should take care of and worry about. If you don't have the means, then yeah.
So our next question is from Jed. They say, you reference Switzerland's status as a long-established neutral power. The very possibility of neutrality in human affairs seems to be increasingly contested in recent decades by some critical schools of thought. Does the destination jurisdiction's commitment to amend neutrality play a role in your analysis? If so, could you elaborate on the significance and of what other means other jurisdictions that allow physician-assisted death? So
I'm not sure, what does it mean to amend neutrality in this context?
I'm wondering, so I'm not sure, and Jed, please add to the chat if you can elaborate. I'm wondering if Jed means that the idea of being neutral itself is contested, and that the attempt to say we are Switzerland, we are neutral, is trying to shape sort of or amend what we understand neutrality to mean. That's what I'm.
Yeah, well, from what I witnessed when I was in Switzerland and doing this research, I think that the Swiss don't regard this as something that is Swiss, something that is, in any way associated with their nationality or with the characteristics of their nation. They see it like an individual. Some regard it as an individual businesses or individual help or humanitarian aid, or we don't care. Okay, so you can see all these spectrum of responses to how they regard this phenomenon. But when I look at it from the outside, and I also interviewed, for example, policymakers in Switzerland and try to beg this question and ask more about the image to Switzerland, and so it does play a role. It does play in a way that it may contest its image as a neutral, and in a way color it in something that Switzerland does not want to be colored with. They still want people to come there for ski and for the Alps, and for chocolate, not for suicides. Yeah. Okay. But it's interesting. I mean, there is a gap between how the lay people and even the organizations introduce themselves in this industry or in this phenomenon, and the way that policymakers or people that regard this from a national perspective.
Thank you. Jed said that answers his question, so thank you.
Right.
So I think the second part of the question was, of Jed's question, was the sort of significance or perception of other countries that might be considering offering this or offering suicide tourism. So is there a lesson there in the Swiss case for other countries who would consider offering this, and how that might impact how they'd be perceived on an international level?
Yeah, I think that most of the countries that legalize, and even Canada, refer explicitly to the fact that they don't want people to come to. But I think that, and from what I saw when I was there, I saw that there is something that providing these services to foreigners is criticized by many, many people within Switzerland. So on the one hand, on the other hand, again, if you believe that this is an important right, and and the person has a right to even receive this humanitarian aid, and if she cannot access these services because of the political, legal, and social constraints in her own country, I would recommend states to rethink this position and maybe to open their regimes. One can still states can limit, in terms of or think of some criteria that would safeguards the potential of abuse or the commercialization and things that also were discussed here. But I think that, as an idea, I think the idea is correct. I think the idea is that people should not be prevented from exercising this very important right.
Thank you, Daniel. And I think that's an excellent point to end on. I see we're coming up to 5 o'clock. So it is, thank you for a great discussion. It's now time to draw our seminar to a close. I have a couple of announcements to make before I thank today's speaker. So first, next week is Reading Week at U of T. So our next seminar will be following the following week, which would be Wednesday, February 24th. And Jennifer Bell will be discussing influence on patient autonomy and decision-making about early phase cancer clinical trial participation. To sign up to receive our weekly seminar reminder via email, please send an email to jcb.info@utoronto.ca. For those of the CSB students who are watching today and enrolled in the CSB Student Seminar course, please remember to keep track of your attendance. And last but not least, Daniel, on behalf of all of us here today, thank you so much for your presentation. It was very informative. Thank you.
Thank you all.